I want to take a deeper dive into treatment and spend a little time here. As no surprise, this was a big area of questions. And I want to start off with some of the most common treatments that most people are aware of, remdesivir. And Dr. Rogers, perhaps I'll start with you and then Dr. Subramanian. As far as when should remdesivir be started, who should be getting it, and just some general thoughts on that.
Again, I agree with Dr. Rohaki's comments at the beginning that remdesivir, that Dr. Subramanian was one of the key authors on one of the largest papers on remdesivir, so I should really defer to her. But it particularly shows a getting out of the hospital sooner if you're in the hospital, and was less clear that it helped people live, survive better. Whereas dexamethasone is really very much our standard of care only for people who have oxygen, less than 90 or 92%. If you actually need oxygen, then steroids helps people survive. On the flip side, as others have said, if you don't need oxygen, there was actually a trend toward harm from getting steroids. So I do worry that in the desire to do something when you're sick, that people are taking a fair amount of steroids and maybe actually increasing the risk of their loved ones. So we really have a line in the sand where if you don't need oxygen, no steroids. If you are needing oxygen, then yes.
And Dr. Rogers, thank you for pointing out, Dr.
Well, I just wanted to add out here that in India currently, the steroids that are currently being prescribed is mostly methylprednisolone, whereas most of the data that we have from the literature that we've seen is with dexamethasone. But what the doctors here tend to prescribe more is Medrol, probably from clinical experience that it works a little better than dexamethasone. Would you be able to comment something on that, Angela?
Sure. Decadron or dexamethasone is not in our ICU experience our go-to drug either. We tend to use, as lung doctors, a lot more prednisone, and methylprednisolone is more our norm as well. But one thing that is notable is that it's not a lot of steroid that's being, the Decadron dose was not super high in the big recovery paper that changed all of our practice. And so I would just be trying for an equivalent low dose, sort of a modest dose of steroids, not huge vasculitis type dosing. But I don't feel strongly about one over the other, but maybe just not giving a lot.
Thank you.
Thank you very much. And speaking of steroids, of course, you've been talking about it already, but I also wanted to loop in both on remdesivir and, of course, on steroids. Dr. Subramanian, who, as Dr. Rogers pointed out, has been involved with a lot of research here, along with Dr. Rohtagi and others. Dr. Subramanian, you wanted to get your thoughts on remdesivir that wasn't already covered, as well as the use of steroids and indications.
No, I totally agree with what Dr. Rogers said. I don't think people need to go out of their way. If there's a shortage of remdesivir, it's not worth paying, exorbitant amounts of money for it and getting it. I really think that steroids are much more important. I do understand that when there's a bed shortage and you want to get people out of the hospital, remdesivir can help, but it's really there's no mortality benefit with it, whereas steroids can really help in preventing mortality. But as Dr. Rogers said, I fear that, and I've heard that very high doses of steroids are being used with the methylprednisolone, and it really should be low dose and limited to 10 days, because as I said, we're seeing complications in people who are taking too much.
Thank you very much. Dr. Rohtagi, any comments as well?
No comments, Dr. Rohtagi, at this time.
Great. I want to move on.
Errol, sorry. So Dr. Subramanian just wanted you to comment on baricitinib, which as we work for, I'm from International SOS, we get a lot of requests from our clients. So we've had some of these requests, and it's been very difficult. It's a very expensive medication here in India. And what is maybe you'd want to highlight on what is the role of baricitinib?
I'll let Dr. Ahuja take that, because she worked on that study very.
Sure. Okay.
Thank you. Yes, myself and Dr. Nadeau worked on this study, and baricitinib is a JAK inhibitor, so it helps with the cytokine storm, but has also been actually shown to help maybe have some antiviral properties. It's an oral drug, short half-life, relatively good safety profile. So head to head with dexamethasone, it looks like it's about even, but may have a slightly better safety profile. The risk of DVTs, PEs was not very significantly increased with baricitinib. So I would say that if they have access to dexamethasone, that's probably the most cost-conscious approach. If they do not have access to that, then baricitinib could be used. Dr. Nadeau, do you have anything to add to that?
No, that was a perfect answer. Thanks so much, Dr. Ahuja.
And thank you for those. I also want to talk a little bit about monoclonal antibodies. It's been a very common question. Perhaps Dr. Subramanian, I could ask you to comment on what are we doing here? What are recommendations? And also Dr. Samir and others to help us understand our recommendations as it relates to what's available in India.
Right. Here we are trying to target people who are at high risk for hospitalization. So we're giving it to people who are outpatients. And Dr. Mahadevan had gone over the risk factors for people who are likely to develop severe disease, and those are the people we're really targeting: the immunosuppressed people, elderly, hypertension, cardiovascular issues, and we are bringing them in early for monoclonal antibodies. But it's it's cost effective here. It's free for patients, and we're able to give it to them quite quickly.
Great. Any other comments from others? Dr. Ahuja?
Maybe if I could say a quick word on monoclonal antibodies, we have studied, there have been numerous studies now looking at monoclonal antibodies in hospitalized patients. So that includes, again, a lot of the patients that you're caring for at home on oxygen, or even room air. And those haven't shown benefit in hospitalized patients in now 3 different cohorts across the US. And so I think, as Dr. Subramanian highlighted, it's for very early. It's not after you've had symptoms for a really long time. It's a minor benefit. So that would be, again, compared to steroids in people who need oxygen. Often by the time you're needing oxygen, it's later in your course. You need anti-inflammatory. It may not help that much. So I would put that in if it's really early and available, great, but not worth spending thousands of dollars trying to find, because it probably won't help, especially later when the person's very ill.
The Prime Minister, Dr. Singh, had also been part of this, and thank you so much for joining. And he did put a question in here, if we can. We're going to keep going on treatment, but I do want to talk a little about treatment in regards to his question. The FOGSI recommends giving COVID vaccine to pregnancy lactating mothers, while our union ministry does not recommend. How do we go about this? And perhaps Dr. Nadeau would like to try and explain that. I think she actually might have disconnected a little bit. Perhaps Dr. Subramanian, any thoughts on this? This was an important question. We actually noted this one as one of our important questions to answer. So thank you for bringing this up now.
Sure, and thanks to the Minister of Health for the question. And yeah, I mean, we feel that it's important to try to vaccinate pregnant women. So far, in the studies that have been done in mRNA vaccines, it does appear safe. And pregnant women are at risk for severe disease and worse outcomes of the pregnancy. So anything we can do to protect pregnant women that's safe for them, we'd like to go ahead. And so far, it does seem that vaccination is a good idea. Some of the vaccines haven't yet been studied in pregnancy, so it's a risk benefit, but we really think that the benefits outweigh the risk. And we think that lactating women, do have an advantage when if they're vaccinated, because they give the antibody protection to their newborn infants. So there is protection that they're transferring. We've had at Stanford many good outcomes from pregnancy, and we've had patients deliver their babies without problems, without getting COVID in the infant or having any complications. So, it can be a positive experience.